I am Dr. Sreeram Prasad. I am a consultant neurologist and movement disorder specialist. I am the head of the Department of Neurology in Lourdes Hospital from 2014 onwards. DBS was started in the second half of 1990s in a patient with the Parkinson's disease. The first case was done in 1995 in France in a patient who had Parkinson's disease with motor fluctuations and disability because of that. After that, the indications of DBS as well as the technology of DBS has advanced. As far as indications are concerned, DBS was approved for other movement disorders like dystonias, tremor disorders, tardive dyskinesias, and tic disorders. And later, many psychiatric indications also came into the picture. The most common being obsessive compulsive disorders or OCDs. DBS is also done in some patients with depression as well. Then regarding technology, the DBS started with a non-rechargeable device. Later, rechargeable devices came into picture, which has got a longer duration. That is one change in technology. And also, later technology also changed with many new devices, and it even reached up to adaptive DBS. The concept of adaptive DBS is that we can record the brain recordings of these patients, which are called local field potentials, and the stimulation can be adapted according to local field potentials. The adaptive DBS has not developed into its full existence. At present, we don't have technology in which we can give minute to minute or time to time stimulation change depending upon the local field potential change. But at present, we can record local field potentials in patients, and also we can use these local field potentials to know when the patient was having the effect of medication, which is we call on state in Parkinson's disease, when the patient was not having the effect of medication, which is called off state in Parkinson's disease, and also we can also know whether the patient has missed their medication or whether the patient is regularly taking medications or not, and depending upon that we can plan our programming depending upon these parameters. Deep Brain Stimulation was started in our hospital in 2020 December when we did our first case, and this is the only mission hospital in Kerala and probably in the country to do DBS. In Kerala, all other hospitals are either a central government institute like Sri Chitra or corporate hospitals in different parts of Kerala. Because we are a mission hospital, we have tried to reduce the cost to the maximum. We are doing DBS at the lowest cost in Kerala and probably one among the lowest centers in India, except for some government hospitals where they get a big aid from the government. Otherwise, in the private setup, we can always tell that we are one among the hospitals where we do DBS at the lowest cost. That is one thing. Second thing is that we have done 29 DBS till now, which is within around 27 months. And we are the fastest center where we reached 25 cases in Kerala. In all the centers, they took at least around 3 to 4 years to reach 25 cases, whereas we reached 25 cases in just a matter of 2 years, which is probably one among the fastest in India itself. And regarding DBS per se, regarding the DBS technology per se or the DBS technique per se, we are doing two types of DBS for Parkinson's disease. For Parkinson's disease, we can do DBS in two places in the brain. One is called subthalamic nucleus and the other is called the globus pallidus internus nucleus. In India, all the cases were being done in subthalamic nucleus alone. Because DBS started with the subthalamic nucleus in the world, later people started adding the second site as well, which is the globus pallidus internus nucleus. The globus pallidus internus nucleus, DBS was almost never done for Parkinson's disease in our country. After my training in Toronto, where DBS is done in both subthalamic nucleus and globus pallidus internus nucleus, I started DBS program here. Naturally, I started doing globus pallidus internus nucleus as well. This was followed by a lot of discussion inside our medical fraternity itself, and there was a debate even on GPA versus subthalamic nucleus DBS in Parkinson's disease, where I was asked to defend globus pallidus internus DBS. And after we started doing GPA DBS, the awareness about GPA DBS increased among the medical community itself in our country, and there are now more and more centers are doing GPA DBS. So we could actually contribute to the growth of DBS and the growth of and the updation of DBS technology in our country. The neurology department in Lourdes Hospital has got almost all facilities for most of the neurology patients, and we do it at an affordable cost. We have got two specialties. We have got movement disorder specialty here, as well as we have got an epilepsy specialty here. We have got an epilepsy specialist. We have got an sleep lab as well for sleep patients, sleep related disorders as well. So we have all these programs running. In addition, we have got all the facilities for a basic neurology setup, like we have got a stroke program, we have got state-of-the-art ICUs, we have got very good neuro labs, state-of-the-art neuro labs, as well as neuroradiology department and neuropsychology department and everything which is needed to support a good neurology program.